Hello and welcome to the webinar. We're excited about your interest in learning more about autism, ADHD, and telehealth, and the key areas of value for virtual pediatric care. My name is Tencel Burke. I'm the Senior Marketing Manager at Anytime Pediatrics, and I'm excited to introduce you to three great panelists today that will be sharing more about those areas of value for virtual pediatric care. We will be recording the presentation today and sharing it as a link and a follow-up so you can rewatch and share with your colleagues. And at this time, I will introduce your panelists. We have the founder and CEO of Anytime Pediatrics, Dr. Mick Connors. He's an active pediatric emergency medicine physician and an innovator in the pediatric industry. We're also excited to have Dr. Barbara Howard, the founder of CHADIS and an assistant professor of pediatrics at the Johns Hopkins School of Medicine, as well as the president of Total Child Health. And last but certainly not least, we're excited to have Dr. Kristin Sohl. She's a professor in the Department of Child Health, the executive director of ECHO Autism, the medical director at Show Me ECHO, the Missouri Telehealth Network. And we're very excited to have all of our panelists to share more with you today. So without further ado, I will turn things over to Dr. Connors.
Yeah, great. Thanks, Tencel. I think today's a fantastic day because it really gives me an opportunity to reflect what Anytime Pediatrics is, which is the connector, the opportunity to use technology to connect pediatricians with expert pediatricians and really get out of the middle of the process. Really, our goal is to keep kids connected to the patients through the medical home or through their specialists. And so today you're going to hear very little, if not anything, from me. Because Anytime Pediatrics' role today is just kind of as an organizer to give you the great insights of Dr. Barbara Howard and Dr. Kristin Sohl, who Tencel did a great job on the introduction. So without further ado, Tencel, do you want to go to the next slide? So again, today it's really talking about virtual care and how you deliver that for autism or ADHD and behavioral health. So we have two world-renowned experts that will cover these topics today that really have amazing content put together for you. So I will be quiet and turn it over to Dr. Sohl so she can enlighten us on how she's utilizing telehealth and more information about her great work in ECHO Autism. So,
great.
Kristin, I'll turn it over to you.
Okay, excellent. Thanks, Mick. It's great to be here. I'm so thankful to have this opportunity to talk to you. Thanks for the introduction as well. You know, I am a proud pediatrician. My specialty is autism and developmental behavioral medicine, but I am a general pediatrician by training. And so certainly my heart is in general pediatrics in many, many ways. And so you're going to hear me talk a lot today about autism, but certainly I have a lot of experience in thinking about primary care as well. So what we're going to talk about today is understanding the value of longitudinal care in autism. We're going to describe the strategies for maximizing value through virtual care for people with autism or kids with autism. And then I'm also going to share with you a little bit about tele-ECHO opportunities and something that we call ECHO Autism for gaining professional development and early identification, screening, diagnosis, and then also that longitudinal care for children with autism in your practice or other developmental disabilities. And so we're going to talk a little bit more about that, but we're definitely delighted to be able to talk with you about these really important topics. So just in the first few slides, I'm not going to belabor a lot of information about the specifics to autism and the prevalence or the underlying diagnostic criteria and things like that. But I always like to make sure that we're all on the same page because autism is frankly an ever evolving topic, right? And so the most recent prevalence data tells us from the CDC that in 2020, which came out right at the very, very start of the pandemic, came out right in about late March, that the most recent prevalence is 1 in 54. So about 2% of the population has a diagnosis of autism. And as you can see, this graph is kind of alarming. It really isn't. There's no need to be super alarmed. But as you know, in pediatrics, we have a lot of parents that ask us questions. Is my child developing okay? Or can you tell me if this is a concern? Should I do something else? What's happening, right? Or you may have a concern. And so certainly when we see numbers like this, it generates more awareness. It generates more concern. And so certainly those are things that in our field, we have to be prepared for. And so certainly it's important for us to be abreast of that most recent information. Also, it's important for us to have at least a solid understanding of what autism is. So I always like to set that frame. So when we think about autism and what autism really is, it's made up of two distinct categories. And so it's deficits or lack of skills in social communication, and then the presence of repetitive restricted behaviors. Again, I'm not going to go into those in great depth today because that would be a whole different talk. And today we're talking really more about how do we bring value to the care that we deliver in our practices. But certainly these are important things to understand. And so if you don't, will be opportunities that I'll share with you later for you to understand those in more depth. But one thing that I think is important for us to know is that autism is much more than those two main categories. And so something that's really evolved over the last decade or two is all of the information that we now know about autism and the other co-occurring conditions that go with autism. So things like other medical conditions and other psychiatric conditions that are very common for people and children with autism. So things like anxiety, things like sleep problems and major challenging behaviors, GI challenges, like constipation or chronic diarrhea, things like that. And when you talk to families, they'll tell you that sure, autism and the autism symptoms themselves are challenging, but often it's those co-occurring conditions that really are the more driver of the issues that their families face. And so the concept that I'm going to be describing to you today is really about that family-centered care. And I will say, as a proud pediatrician, this is something that I think we do very, very well in pediatrics. And I'm going to describe to you today how I think we can continue to do that through telemedicine. So as a medical home, we often are seen as that hub, if you will, of providing care to families. And so when we think about family-centered care, and what does that mean? Well, in our space related to autism and developmental disabilities, it doesn't start and end with a diagnosis, but it includes helping to coordinate that care. No, you don't have to do it alone. You have team members, you have therapists, you have social workers, you have other people that may or may not be in your office, and oftentimes are not. So my heart is very much in rural and underserved populations. And while I am at an academic center, I'm in Missouri. So many of the places that I work with are in very small towns. And so we don't have the luxury of all being under one roof, which is where telemedicine is a great advantage, that we can work together and we can work across space and time to really support our families and still deliver best practice care in that family-centered approach. But one of the things that's important to understand is that the state of care pre-pandemic, and frankly, pretty much still now, is that the diagnosis and frankly, the ongoing care for autism happens mostly in academic or certainly in autism centers. They aren't always attached to large academic medical centers, but the vast majority are. And so what does that mean? That means that families are having to navigate their way to academic centers or again, autism centers that are typically found in larger urban centers, larger urban populations. And so what does that then translate into for our smaller towns, for our patients from different racial and ethnic backgrounds? Well, the literature is very clear that there are clear disparities in autism. So we both know that racial and ethnic disparities exist, that are there's progress being made in those areas, but certainly we know that that is a big issue. We also know that the children who have developmental concerns and concern for autism can be diagnosed with autism as early as 24 months and reliably diagnosed at 24 months. And yet, in the United States, the average age of diagnosis for autism is over 4 years of age. All of us as pediatricians or pediatric providers know that 2 years, so 24 months to over 4, is a lot of time in development. And that's a lot of time that is kind of frankly wasted, right? And so what does the state of our care tell us about how we are delivering that care to patients and families who need us? And so sadly, right now, our system is designed to move patients to higher orders of care, higher places, higher, bigger centers, bigger specialty organizations, things like that. And while I understand that, and I know why that's been done, that also really does continue to hardwire those inequities and inequalities in our system. So it's important for us to just kind of understand that. And I'll share with you some of the experiences we've had and the work that we've done related to some of the the post-pandemic work as we go. But I think it's important for you to understand, what is the role of continuous follow-up care in autism? So here's the thing that's important for us as pediatricians to understand is that we as pediatricians have a major role to play in autism care. And yes, I am a specialist and I do practice, again, specialty developmental behavioral pediatrics. And yet much of the work that I do in this space for longitudinal autism follow-up is something that is bread and butter pediatrics. And I'm going to show you why I say that here in just a minute. So here's what this looks like. What I do in these longitudinal follow-ups is essentially assess educational supports. How is therapy going? How are behaviors? How's progress? Looking at a screening for underlying medical conditions like sleep problems, like constipation, like, is your child having staring spells? Are you concerned about seizures? Things like that. Anxiety, ADHD, things of those nature, all of, again, which may seem, especially if you hear maybe anxiety or some of these other issues, you may think, oh, I don't do that every day. But constipation and sleep, and I would argue probably looking at staring spells, I'm not going to treat those seizures, but I know how to refer for those. And I also know what to do with sleep concerns, right? So those are things that we do in pediatrics all the time. Checking in with the family is really important. Autism can be tough and it's a full family. It's a whole, it impacts the whole family. So checking in with the family is really important. And then linkages to resources. And of course, certainly not every practitioner out there is fully familiar with every autism resource in their area, and that's understandable, but certainly there's opportunity there to learn as well. So when I'm practicing and I'm seeing children for longitudinal follow-up and they have a diagnosis of autism, these are the things that I cover in those visits. And then you may be thinking, well, how often do I see them, right? So if it's a toddler or a preschooler that I've just made a diagnosis in, or again, in that age range, I'm going to see them about every 4 months and cover those topics that we talked about. If they're school agers and things are going relatively well, we kind of call that the honeymoon phase, if you will. And school age, I'm meaning more kind of first grade to maybe fifth grade. Then I'm going to see them maybe every 6 to 12 months. It kind of depends on how they're doing. There's a lot of depends here. And the reason that is because autism is highly individualized, right? So many nuances to that care. Are they having behavior challenges? How's the family, social, emotional, all of those different things. And as you can see, the frequency can increase or decrease based on how things are going. Also, though, things that we are looking for, and this is, again, things that we do as general pediatricians all the time, are there times of major transition that are coming up? The start of kindergarten is often a very big one for children and families that are going into kindergarten, because the big question is, will they need supports? Will they not need supports? And so it's often a period of a lot of anxiety for patients or for parents, particularly. Usually the 5-year-old's not too aware of the big change that's coming their way. But same thing with puberty and middle school and starting or graduating from high school. So we might see those children and their families a little more frequently during those times. But as you can imagine, it's often a lot about just supporting those families through those transitions. So my visits are often spent talking and thinking about, what do we need to think about next? How's your child doing in these various areas? Have you thought about this? Have you thought about that? Tons of anticipatory guidance. And so certainly that brings me to that topic, right? Anticipatory guidance. And I love teaching this to my residents and my students and my fellows and thinking about, well, what exactly does that mean? And what is the role of that? And so certainly being proactive, thinking ahead about what parents can anticipate during that next developmental phase of their child. And in autism, it's not a lot different, but certainly there are some definitely special things that you want to talk about. And so in this space, and what I'm going to talk to you about is how we get to do this through telehealth here in just a minute. But I wanted to give you a foundation of what longitudinal care looks like, because it's really, as I'm imagining you might be thinking, not that hard, right? So what would I maybe talk about if it's a little person with autism getting ready to transition to kindergarten? Well, we're going to talk about how to help them know what to expect at school. So a child with autism struggles with transition. They may have a hard time getting used to those sights and sounds of a brand new building with lots and lots of more people than they may have had at their preschool or at their daycare. So talking about making time to visit, making time to meet the teachers, again, experiencing those sights and sounds of the school, talking about resources that are available, like a social story. If you're not familiar with that, I'm going to show you one here in a minute. And so you'll get a chance to see what that looks like. And then again, I'm not going to go through each and every one of these, but you can see anticipatory guidance is very similar to what we do every day in our practices, but there are just some subtle changes that we make when we're talking to children with autism. Certainly transition to adulthood is a big one. Whenever you're working with a family who has a child with special needs, thinking about that transition to adulthood is a big deal. In fact, there are huge initiatives. One's called Got Transition, and then there are others that really are thinking about how do we make sure a family, as their child is progressing through adolescence, is prepared and ready for what that adult space looks like. Sadly, all too often, it is very much they call their pediatrician and the office says, sorry, your child's 18, you're going to need to find a new doctor. Just happened to one of my patients 2 days ago when I saw them. And that is a really, really difficult way to learn that your child is no longer going to see their favorite pediatrician, right? And so certainly there's approaches to that. And so those are things that I spend time talking to my families about. And those discussions start at the age of 12 and happen every time annually, basically, after I see those families 12, 13, 14, 15 years old, and we start talking about those opportunities. But I'm not an expert in, adaptive skills. And so it's my job to help think about how to connect them to those things. And so those are certainly things that we work through. And so what I want to think about now is what has my life looked like as an autism specialist since the pandemic. And so this is where the fun part gets to start. So I want to share with you that I had experience using telemedicine prior to COVID-19, but I also I got a chance to really dig deep into telemedicine after March 2020. So I've been using telemedicine since the beginning of my career, so about 13 years ago, using it in that traditional sense where we would see patients at their own, local clinic, and I would be in my clinic, and we would use kind of the big telecom equipment and all that stuff, or that more traditional equipment. But they would still be in a clinic, and I'd be in my clinic, and so very much that traditional sense, not consumer based in their home, very telehealth now, like what we think of. So now I'm going to share with you a little bit about what I'm doing now. So to give you insight into this, I have not seen a patient in person since March 24th, mostly out of choice, and I'll share with you why. So here's why. When I think about it, if I were going to go into clinic right now and see a child with autism, I would need to wear a mask and goggles in order to see that little person. Most of my patients have been with me since their diagnosis. And because you'll hear more about what my program is that I do most of the time now, I'm not in clinic that often. And so I spend a full day a week in clinic, and I haven't done as much new diagnosis work in a couple of years. So here's why I say that. So I say that to mean that most of my patients have been my patients for a long, long time. I take care of around 1,000 patients, and so they know me really well. So the idea of them coming to see me and me being covered up would be pretty upsetting to them, to be honest, right? So I know my population. I know that they like structure, they like consistency, and seeing their Dr. Sohl in a mask and goggles is probably not going to be their favorite thing. So I thought, I know how to do telemedicine, and this will be a great learning experience for everybody. So we did it. And now let me tell you how that's gone. Okay. So first we're going to talk about ways and strategies to engage. I'm going to show you different ways that we've worked on health literacy with families and different ways that we've done that. And then also space to connect. And I'll talk with you a little bit about that as well. All right. Oops, there we go. So here's what's really cool about doing telehealth or telemedicine with patients with autism. I get to see their interests. Now, of course, we know with autism, it's not overly exciting for them or they're not overly interested in sharing their interests, and every patient's different. So some of them do want to show me things, and some of them, again, are very much, the classic in your own world, not terribly interested in seeing me on, in any which way, but certainly the ones that do can show me all kinds of things, and it's been really delightful to see. I've gotten to meet so many pets and so many different things. They take me outside, they take me to their room, I get to meet siblings and all kinds of stuff, right? So I've gotten to see collections of all kinds of things, and imagine the insight that I now have into my patients that I've taken care of, some for, again, 13 years and some for, a couple of years, but certainly that gives me insight into things that I never had before. And so I'm able to observe their behavior in a different way. I've also been doing some new diagnosis through telemedicine. Again, I like to try new things, and I'm also a QI junkie. So I do a lot of quality improvement on myself and on everybody else around me. So look out if you ever do things with me. I like QI. So I'm constantly doing PDSA cycles, and I decided to do that with some autism diagnostics. And so I tell you what, the insight I was able to gain by doing autism diagnostics through telemedicine was remarkable. Being able to see them in their own natural environment and observe their behaviors with someone when they were comfortable with their own parent and watch their interactions was amazing. Was it perfect? No. But was it awesome? Yes. And so it's definitely been a great opportunity to really get a bird's eye view into their space. And I really have appreciated that time. So certainly love a lot of the ways that we're able to engage. I will also say that I have a lot of strategies up my sleeve to try to help them engage back with me. So how do I do that? So I have a lot of virtual backgrounds. And so I don't always engage them with my virtual backgrounds, but sometimes I do. And so, you know, of course, I could be super professional and use fancy virtual backgrounds like this one, but I typically don't. But I have a bunch, probably about 60 to 70 different virtual backgrounds that are saved in my Zoom account, which is what I use for my institution's telehealth platform. And, you know, we'll often start the conversation if the kiddo doesn't seem terribly interested in talking to me, or maybe if a topic comes up, I'll say, oh, you know, do you like such and such, right? And then I'll say, watch, you know, do you want to do you like dogs or do you like cats or whatever? So you can see here, I've got a plethora of different things that I can have behind me that they love. And I'm telling you what, they light up, they get excited. And so if I need to talk to mom or dad for a little bit, then they get all excited about the things that are coming up behind Dr. Sohl. And certainly it's pretty exciting to watch them have fun and I have fun. And so it's been really great. I will tell you, I ran a short little PDSA cycle this past week in clinic. I'm a cat lover, so bear with me as I explain this. I normally don't allow my cats in my office on clinic days, but I forgot this week. And so my one cat who's always in here with me was here and I forgot. And so my one patient started out, you know, I started out with clinic, turned on Zoom, and all of a sudden I'm like, oh, look, there's a cat. Anyway, the kids absolutely were in high heaven with this cat behind me. And so I decided to keep trying it out throughout the rest of the day. And they loved it. And so they just kept saying, oh, look, you know, and they would point to him. And again, yes, these children, I promise you, have autism, but they were highly engaged in talking about the cat, then showing me their pets and doing all kinds of things. Obviously, these kids have a lot of therapy. But again, great opportunities for me to see them and just to have opportunities to talk to them. So certainly lots and lots of fun. So you can do all kinds of neat things. And I love getting a chance to do that. So then thinking about how do we support parents through telehealth during this time? And so one thing I love, and this has been delightful and kind of a delightful surprise, if you will, about this as well. So in traditional clinic, I would offer them lots of handouts, you know, and I'd give them packets about toolkits, or, you know, I'd have them bring to me their IEPs that I could look at, or what have you, lots and lots of paper. And now instead, I can go ahead and pull up the very thing that I want to show them. Now, I'm not sure if these links are going to work. I think they may, but I don't know. So I tested everything last night, but we're doing it a little bit differently. But anyway, I was going to show you how this looks in real time. But the cool part about it is I can actually pull that link right on up on the screen and show it to them right then and there. And that is a great opportunity for families. And so I can walk it through with them. And I can even watch a little video with them if I want to, and teach them right then and there, whatever it is that I want to show them. So this was the social story I was going to show you. But, you know, during the early days of the pandemic, we'd spent a lot of time talking about COVID, strategies for wearing a mask. You know, I'm a big believer that mask wearing is a measure of health equity. So of course, kids with disabilities, particularly autism, it's a challenge for them to wear a mask, but that doesn't mean we don't try. So those masks exemption letters that I bet all of you have been asked to write, think twice about that, because what is that saying? It's saying that that child does not deserve to have a safety measure like everyone else. We would not write an exemption letter for a child with autism to not sit in a car seat. So let that sit with you for a bit. What I would encourage you to do is work with that family to learn and have strategies to help that child wear a mask. And so it is a health equity situation, and treating them like they are not able or capable is really not true. And so it's an important thing for us to think about. But here's an example of one of those videos. So a lot of my kiddos have anxiety. So watching this with them or sharing this link with them is really a great opportunity. And then I can turn around and send them the active link in that chat box. And so I instruct the families to then click on it. So that way, when the Zoom session ends, or the, you know, whatever you might be using for telehealth ends, they've got that link right there. They can bookmark it and away they go. So a whole lot better than handing them a packet that they leave in the car or throw in the trash on the way out the door, and have a lot of opportunities. So then on your side of things, so how are you connecting with the families? I do want to mention that it is important for you to know that you are going to get a glimpse into social determinants of health that you may not have been prepared for. I have seen food insecurity like I never imagined. I am the president of our chapter of the American Academy of Pediatrics here in Missouri. I have extensive experience in advocacy, both at the community, legislative, and federal advocacy level. And I will tell you, I know social determinants upwards, backwards. I've done tons and tons of volunteer work, and yet I was moved to tears on more than one occasion when I first started doing in-home visits through telehealth, because it's something different when you get to see families in their own environment and you get to witness the depth of what they're experiencing during a pandemic, and the fear and the absence of what they don't have. And so it's certainly something to know. Now, fortunately, as pediatricians, we often know what to do and how to link them to the things that they need. And so that's also an opportunity to advocate and to connect. So I like that. Health advocacy in action is awesome, because here's what I mean by that. You can say, go grab that pill bottle. Let's see what your dose is. Go show me how you take your medicine at night. Go grab that for me so we can talk about it. That has been incredible. It's been really, really helpful. And stories from friends that are doing telemedicine in the adult space, it saved lives. Being able to see that they're not taking the right doses, or that they're taking a vitamin instead of an actual prescription medicine. These are things that telemedicine brings to life, and it's incredibly helpful for our families. And with autism, honestly, it's been such an easy pivot from what I was doing in person that I honestly would love to not go back. But at some point I will need some vital signs. So I will mention that here in a minute. But it also allows you to continue being part of their family. Families are lonely. Families need you to connect with them. And so this is an important way for us to continue to connect. One other interesting thing that I've found is this also allows families to step out of the room when they want to talk about something in private. One of the things that's really hard about autism and developmental disabilities and behavioral challenges is that we're always having the family talk about their kiddo's behavior issues in front of the kid, right? Now, I'm one of those people that I'm like, I'm sorry, the clinic doesn't have an extra room or a babysitter for you to move your child to a different place so that I can hear about your child's behavioral challenges. We're just going to have to do the best we can. But now I can actually, the mom can go to her room and close the door, or she can do something different while she, wants to share those more intense situations with me. It's a really great opportunity. Similarly, the child, if he wants to talk to me himself, or she wants to talk to me herself, can do the same thing. It's been a really huge benefit. So thinking about pre-pandemic, these were kind of the barriers and disruptions to care. We had issues with distance and cost and time off work. Obviously still have tons of workforce shortage issues and safety. So patients having a lot of behavior challenges in the car en route, the 2 to 3 hours that a lot of my patients drive to come and see me in person. Post-pandemic, we still have workforce issues. We still have device access, or now though we have device access issues. Some families don't have a device. Sometimes we have broadband issues, and we do, like I mentioned, I can't get vital signs, at least not currently, although I have some ideas that I'm currently playing with. And certainly though, we still have workforce shortage issues. And so certainly that continues to be something we have to think about. And so one thing I would encourage you to think through. So perspective is a big deal, right? And so perspective about how we all come together to improve outcomes. I'm a specialist, like I said, but I'm trained as a generalist, and I practice general pediatrics as well. And so as a specialist, we often think about, well, how come the generalist can't do more? We've made all these tools for them. How come they can't use them? And then I know that as a generalist, you're busy, helping so many families in so many ways and doing so much in a very short amount of time. And you're asked to see more and do more every single day. I also know that general pediatricians get 4 entire weeks during your entire residency to learn all of developmental disabilities and the differences that we experience in development. That's not a lot. Then I see the families, and the families don't know any of that. They don't know that pediatricians have those 4 weeks. They don't know that all of these different things exist, and the families just want help. Families want to know what to do and how to go about their lives next. And so certainly I like to think about reimagining the system. So as a specialist and a researcher, we are constantly discovering new things. And I know that it takes a long time to get those new things integrated into clinical practice. And then I know it takes even longer to get policy change out of that. And so how is that impacting our families? And so certainly we are working hard to come up with new ways to do things. So there is a program called ECHO, and it stands for Extension for Community Healthcare Outcomes. It was created to help hepatitis C. It was generated by, or initially created by a gentleman named Dr. Sanjeev Arora to tackle the condition called around hepatitis C. Now, fast forward about 15 years, and it's now being used all around the world for many, many conditions, and is a very key player in combating COVID-19 around the world and disseminating knowledge quickly. I adapted the model in 2015 to autism. We call it Echo Autism. And here's really what it's all about. It's about mentoring and partnering with generalists. And so it's not about me saying like, hey, you need to do more. It's about me mentoring me as a specialist and me and tons of specialists working and mentoring generalists to help build capacity in smaller communities and also grow local expertise so that we can come together and provide better care. It's also about consistency and access. So you have a team of experts that you can come to work through your own real-time cases and share knowledge back and forth. It's also about me learning. I learn so much every time we come together, and it's all virtual. So I don't leave my office. You don't leave your office. It's free. You come together and you get evidence-based recommendations to take back to your practice and really continue to grow your knowledge and skills around development, around autism and other developmental disabilities. Certainly, I'm not going to spend a ton of time here because I want to make sure Barbara has tons of time to talk about her topic as well. But the whole notion here is to learn interdisciplinary care in an interdisciplinary way. And so our team is made up of all the people that you would need in order to answer some of the questions that you may have. It is not designed to teach you to be a specialist. It's designed to teach you how to be the best you can be in the primary care space. We have gone on to build out many other kinds of Echo Autism programs. These are just some of them, but we are training parents through Echo Autism as well to be family advocates for their community, to be empowered family members so that we can disseminate best practices, so that we can make sure that families are getting the best information about everything from vaccines to chelation to diets and to where to go for diagnosis. All of those things are really important as we try to really change the tune or the dynamic, if you will, about where people seek information so that we know that that quality information is being sought and shared among our communities when there is a question of autism or when a family has autism. So certainly our results we're really proud of. So these are our Missouri results. We also have about 40 other institutions around the United States using our model. And we also have about 15 different countries that are in various stages of launching their Echo Autism programs. But here in Missouri, every child, not just child with autism, but every child in Missouri is now within 60 miles of an Echo Autism trained primary care provider. We also have a model here in Missouri that we call Echo Autism STAT. So 30 primary care providers, mostly physicians, but a handful of nurse practitioners are also trained to diagnose the most obvious symptoms of autism. So that child never has to get in the queue, the long waitlist queue. And certainly we are proud of that because we know the earlier access to autism diagnosis, the faster those kids can get into intervention. So our numbers are great. We are so thankful for the teams of people that join us every month, and we are thankful for that. So I'm going to go ahead and pass it back over to Mick to turn us over to our next speaker.
Thanks, Kristin. That was great. I don't know if you all have heard Dr. Sohl speak before, but her enthusiasm and passion is just awesome. And I'm, as a change agent too, I'm addicted to PDSA cycles as well. So, I mean, it's constantly, how do we innovate? How do we improve? So, that was certainly fantastic. It's my great pleasure to introduce Dr. Howard so she can talk to you about, again, another pediatric innovator who's been doing this for a long time and really kind of not only impacting behavioral and developmental pediatrics for herself and her practice, but certainly through her work on CHADIS and the like. So I will turn it over to Dr. Howard. And also, in the interest of time, I mean, we'll probably run over, as you can tell today. So feel free to use the Q&A feature if you want to ask questions for Dr. Sohl. I know folks are busy. If you need to drop, that's fine. We'll record the full session and we'll stay as long as the last person wants to stay. But certainly it would be great to use the Q&A session if you have questions for Dr. Sohl, and there'll be time, hopefully at the end, if you're able to stay on as well with Dr. Howard. So thank you all again. Turn it over to you, Barbara.
Great, thanks, Mick. And I hope everybody listening to this appreciates what an amazing force Kristin has been in helping children with autism. And Kristin, I admire your work very much. I'm also a developmental behavioral pediatrician, and I practice primary care. And I'm also the creator of CHADIS, so I have a disclosure about that. And our CHADIS system is partners with Anytime Pediatrics, so there's a disclosure for that. Nick has already laid out the objectives for my part of this discussion, which has to do with ADHD and mental health concerns and how telehealth can help. And it's important for you to understand my perspective on CHADIS because, let's see, I hope it doesn't advance automatically. CHADIS is a clinical process support system that helps with care by allowing patients to do questionnaires remotely before the visit, which nowadays is practically everybody, right? Can also be done in the waiting room. And then there's decision support for shared decision making, which Kristin referred to, and as well as for making referrals during the visit. And then after the visit, the ability to convey educational materials and resources and to provide monitoring for the patients over time. So the sequence of it is a parent doing questionnaires from home, teens under a separate login, neither one sees each other's data. The clinician sees the results and can exchange information with teachers, therapists, etc., provide education in individual care portals, earn MOC credits, and actually it's also billable to insurance, which is important to everybody these days and days before as well. So what is it that is important about telehealth? The preparation for the visit offers new opportunities. It's always been important to have information before the visit if you can, but it's really critical for telehealth visits because you have a different situation that you're dealing with where someone can't hand you pieces of paper in the way they could before, even though they might be able to show you on the screen. So collecting patient data before they come in and having access to that is ideally done electronically, such as through CHADIS, where you can get both comprehensive evidence-based tools done and also a way for positive results to trigger follow-ups so that you've refined the information remarkably. Now, there's no travel time, which makes repeated visits important. Now, Kristin laid out the importance of repeated visits for autism, but actually for ADHD, often repeated visits are even more important because you're making adjustments to medication, which you're not always doing in the case of a child with autism. Most of them don't need medication, although many do. And also the development of comorbid symptoms. Now, comorbidity also applies to autism. So making it feasible for the family to do repeated visits is actually invaluable. This is something that we're really excited about. And I share Kristin's excitement about maybe never wanting to go back from that point of view. The other thing that is true in developmental behavioral pediatrics is that by having information before the visit, you can often triage who needs to be present, what kind of team might be needed, and what are we looking for. And this is a great efficiency because often developmental behavioral pediatrics has been done as a team where there are multiple people seeing the patient on the same day, the patient's there for hours, sometimes all day long. Well, that's actually not really feasible anymore, nor is it safe. So being able to collect information to decide who needs to see the patient is really important. In many cases, people don't even make the appointment until the questionnaires have been completed. And there's a couple of benefits to that. There's an obvious benefit to the clinician because you have the information in advance so that you can focus on the most important parts of the visit. But the other thing is it actually engages patients so that they're more likely to show up. And as our daughter, who's a child psychiatry resident, says, it reduces no-shows a lot because you can actually just call the patient up and say, I'm ready to see you now. And they say, oh, I forgot. And they say, it doesn't matter what you're wearing, turn on your televisit so that you can actually reach out and access people directly. So helping with documentation is really important in another way. And that is one of the problems with televisits, and you're probably experiencing this a little bit right now on the screen, and that is we tend to look at people's faces, right? Well, if you're really looking at their face, you're not typing on the keyboard. That would seem like it was especially rude in a televisit. And so having documentation assistance is really important. And then for care of ADHD and other mental health problems, getting input from other people is really critical. And that has never been an easy thing to do. It's always been an important thing to do. There are estimates that pediatricians have input from teachers less than 20% of the time in caring for kids with ADHD, which is a big problem. But when the parents can initiate an email to the teacher with a FERPA compliant consent form built in, which is what's available in CHADIS, this actually allows you to get input from multiple teachers or other caregivers or other parents. You know, we've got a divorce rate in this country of about 50%. What does the other parent think is going on? Those things are really big advantages. So here's an example of data from the MTA study of ADHD. So these are children who were managed with information back from the school feedback. 56% of them had normalized their ADHD scores compared to 25% who were getting regular management by community physicians without the assistance of teacher feedback. So that gives you some idea of what kind of huge difference it can make to have input from other people who are involved with the child. So in terms of the documentation burden, I mentioned the eye contact part that's really important. But keep in mind, and you probably know this for yourselves, those people who are listening, and that is documentation burden is actually one of the largest culprits in clinician burnout. And so having some help from pre-visit data is really important. Okay, now let's talk about what happens actually during the visit. So I mentioned documentation, and Kristin talked very nicely about how having family members participate is really important. They can, of course, get a telehealth invitation, but sometimes they're just home. They're there, and you can say, why don't you get grandma over here and have her explain to us what it's like for her when you're at work and she's taking care of this child with ADHD. You can observe family interactions. You can observe the home environment, as Kristin said, which can be a big surprise. But you can also ask the child to do tasks. So sometimes that's part of what you want to do in ADHD is to have the child do some kind of a test. If you can send testing materials over there by email or mail in advance, that's good. But sometimes you can also just ask the parent to provide the child the instruction. Now, when parents often model what it's like with compliance without even meaning to during television, you see some spontaneous behaviors that you may not have an opportunity to see if they were in a more constrained a visit. And then you can also share materials, share information. So shared decision-making is actually a suggestion of the Institute of Medicine that people should be doing that. And there's a couple of ways that sharing graphics of the progress of a patient really makes a big difference. I'm flipping, it's flipping around. Okay, I'm going to try to go back. Okay, so, and actually getting information for monitoring symptoms and sharing it with the patient is really important to a successful treatment program, because when the patient, you and the patient are both looking at the graphic together, they're more likely to be adherent or to be able to be open to a change in management when they can see that, that a symptom is not responding. So here's an example of a depression graphic. This is automatically created in CHADIS. You can do it other ways as well. And this is an example of an ADHD graphic. So these are the Vanderbilts portrayed in color, where green is good and red is bad. Reds and yellows sync to the bottom of these columns of inattention symptoms and hyperactive symptoms. And the dose of the medicine has been entered by the parent through the computer. So you can see at a moment that there's more green now on 30 milligrams of Adderall than there was here on 20 milligrams. And you can compare the parents' responses to the teacher responses on the same graphic. This is something I do at in-person visits as well, but it's definitely accessible for televisits. And actually, it's usually, I should say, do a placebo-controlled trial where this kind of graphic is created for each week for 6 weeks, where some of the weeks are placebos and some are low dose and some are high dose, as a way to quickly determine the effectiveness of a medication and share that information to decide about use of medication. This is great for removing some of the fears as well. So what's different about televisits for ADHD? Well, frankly, you only need a physical examination initially, and you can have the parent weigh and measure the child, or send them to a drugstore to get a blood pressure and pulse measurement. So those are some things that people are doing now in the age of COVID. Of course, it can be harder to constrain the child and avoid distractions when you're not in a visit room that's 8 by 8 feet or whatever you've got in your office. So that's one of the things that can be more difficult, and a good idea to actually send an information sheet in advance about how to prepare the environment to have an effective televisit. Sometimes it's hard to keep a busy kid in the camera view, and there's often less privacy. Now, Kristin mentioned that you can actually sometimes get more privacy because you can send the kid out of the room, but keep in mind that a lot of people have cars and they may be able to do the visit, the visit in the car, part of the visit, in order to have complete privacy. So being prepared to let people know about that's important. Of course, it's harder to administer direct testing, and you need a way to be able to get Schedule II prescriptions handled either electronically or mail them to the patient, which is different than an in-person setting. But, and the payment for the services is still under negotiation. So under COVID, we don't really know what's going to happen to reimbursement, payment for televisits. But because of the new E&M coding based on time, I think it's possible that that billing for ADHD visits will not be dramatically affected, but we'll have to see how that works out. Now, how about after the visit? What's different with telehealth? Well, you want to give people handouts, but actually one of the problems with COVID is you don't actually want to hand paper. You don't want people handing paper back and forth. You don't want them getting that close to each other, and you don't want to be passing materials back and forth. So having educational handouts and resources sent to that care portal in CHADIS, where they will also get, the patient will also get a text message or email alert that they've got materials to look at, can be very valuable. There's actually a developmental curriculum built into CHADIS for children who are doing ages and stages questionnaires, for example. And the teenagers can see materials separately from the adults. The adult doesn't necessarily even know the teenager got a particular kind of handout, and that can be very important, particularly if you're having a substance use conversation with the teenager, which may very well come up in ADHD because there's increased experimentation in kids with ADHD. Not increased abuse, by the way, increased experimentation. So it allows clinicians to send private notes separately, and this is often a big problem with electronic health records, where access to the portal shuts off at a certain age for the parent and is not available to the kid separately from the parent up to the certain age. Sometimes that age is 13, sometimes it's older than that, which is a big problem with electronic health records and providing materials. It's also possible in CHADIS to schedule questionnaires to be assigned at intervals automatically, and to make eFax referrals directly out of CHADIS with a consent form and a loop to find out from the referring person, the person you're referring to, what happened to the referral. Now, monitoring is key. Monitoring is key to the management of ADHD. So using teacher and parent checklists and work samples and report card data are part of the American Academy of Pediatrics recommendations, and actually anybody else's recommendations. And placebo trials, as I mentioned, are very helpful. So why do you need to get them back? Well, first of all, to make sure you've optimized dose. Oftentimes in general pediatrics, one of the problems with ADHD management is the pediatrician starts a dose, the parent is delighted, things are better, and they say, come back in 6 months. Well, that's actually not the best way to do it, because that small improvement in behavior is not really optimizing where you could be. So managing medicine, especially initially, is really important. Again, why easy repeated televisits are good and why placebo trials are good. Then you want to be managing medication side effects, monitoring growth, vital signs, and especially sleep, and watching for the emergence of comorbid conditions, as well as setting behavioral goals for change. So we don't cure ADHD. I'm sure you know that by now, but you can set goals for change with ADHD, and that is actually one of the basic recommendations. CHADIS has goal questionnaires as well, but you also want to be watching the child's concept of themselves and the perception of the parents, as well as progress towards asset building. So making sure that a conversation about strengths and goals for building on strengths is part of the care of kids with ADHD. Now, ADHD is like other chronic conditions, right? It needs this kind of monitoring and accurate detection of symptoms. But with chronic conditions, there also may be a greater risk. And Kristin didn't mention the fact that children with intellectual disabilities are actually more prone to get COVID than other people. It may be because of that issue about masks, but also there's more difficulty with social distance when children need actual physical management, where adults have to be touching them in order to help them get through their educational day or even their day. We also know that with COVID, there's more problems with mental health conditions, and ADHD sets a whole family at risk when the child's behavior is out of control. So making sure that you have more frequent visits for kids with ADHD is actually highly recommended during COVID, because things are not what they used to be. And so it's important to make sure that we know how our families are doing. It also helps support practice income, which has been greatly reduced by COVID. So what about those e-handouts that I mentioned? Well, there's never enough time in a visit to discuss everything, and people don't remember everything you say. So you could email or text or snail mail handouts, and your electronic record may have some. But being able to trigger individualized health education e-handouts through a system like CHADIS, where they show up in a portal, can be very helpful to them, including care plans for ADHD. And that referral functionality that I mentioned provides a consent form and consent things. So we're going to talk briefly about the importance of questionnaires. I'm looking at the time here. Keep in mind that clinical assessment alone only detects about 30% of children with developmental delays. And so standardized developmental screening is really important. The same thing, maybe worse, is true for mental health conditions, where only 14 to 20% of kids with mental health disorders are picked up by pediatricians without using some kind of screening tool. And even when the child is well known to an individual pediatrician, they still miss it half the time. So that's why it's important to have use of questionnaires. This is also true for psychosocial concerns and even for the chief concern for the visit. In adult visits, only in 37% of the time, the physician never even asked the patient what their main concern was. Now, that makes me ashamed of medicine, if that's true, but there are a lot of reasons that can happen, and having that collected in advance is valuable. Patients are also more honest to a questionnaire than they are even to an in-person visit. That hurts my clinical heart to say that, but it's true. So multiple studies have shown this. So that's an important thing to keep in mind. And patient-generated health data have been shown to improve both doctor and patient satisfaction, to improve the interaction, and in the case of adults, to decrease emergency room usage and even reduce cancer mortality, believe it or not, because there's more information available for the timely discovery of issues. And, you know, clinical observation has its weaknesses even when you're in person. So people nowadays are more afraid of coming for visits. So using a televisit may allow you to have access to people who were avoiding you, not because it's you, but because you're in a medical setting. So those are all important reasons for using televisit. Now, keep in mind that another reason for using structured questionnaires is these are billable to insurance. And there's a number of tools that are relevant here to the care of kids with ADHD and the comorbid conditions, and also, of course, for kids with autism that can be billed to insurance. Monitoring itself has a billing code right there, something worth looking at. Requires consent to do it. So keeping in mind that these are all components of care of kids with ADHD, different questionnaires can help with different parts of that. There are intake and screening questionnaires. There's data collection tools, including for goals, development, emotions, strengths, medication side effects, sleep, substance use, comorbid mental health conditions, autism-specific symptoms. There's often an overlap, social determinants of health, and teacher input. So all of those should be in your wheelhouse, and they can all be collected in one place by CHADIS. There are also tools that are diagnostic level tools, such as the Child Behavior Checklist, the ABOS, or the CARS. Those are things that are helpful to have. and social determinants of health tools. So the way CHADIS assembles all of this into one report is through something we call the patient-specific template, because it's a template for ADHD care that actually is pre-populated by the results of questionnaires, provides the decision support through links, the Vanderbilt graphic, automatically creates a 504 request or IEP request that is delivered to the care portal for the family to provide to the school, and provides that patient-specific education and custom reports. So here's where the report is being generated automatically. So far, the doctor has touched nothing in the PST. Here's where they get content for the care portal sent directly to the patient. It shows up in their care portal listing. Sorry, it's hard to follow. Right. There are handouts, such as this. There are agencies available like this. Okay, so that's my part of the spiel, and I hope we have a few minutes to see what kinds of questions people have asked. Oh, I do want to invite everyone to we don't have an echo, but we do have a case conference once a month, Tuesday at 12:30 Eastern time. Anybody can join the case conference and earn CME credit, and we have 2 developmental pediatricians and child psychiatrists as part of the collaborative office round. So please join us. Just send me an email and I'll put you on our listserv.
Thanks, Barbara. That was fantastic. You know, I think we certainly are getting questions. We'll get have folks use the kind of the Q&A portal that's there to ask any questions. We'll monitor those. I guess the first question, Barbara and Kristin too, you know, for I'm a pediatric emergency medicine physician. And so the screenings, how do you translate all these different screening questionnaires into ensuring that pediatricians have the training and ability to take those screening questionnaires and translate them into interpretation and diagnosis and action? Is there a big gap there, or how does that manage when I see so many questionnaires? How do you know what's valid and how to act on it?
Right. So so in general, this is part of an educational process for pediatricians, and I have to say that teaching about screening tools is not a very big part of training in general. So you have to do some self-education. You can learn more about it during our case conferences if you want to. But what we've done in CHADIS, which is different, is that you don't just get a numerical score back. There's a little interpretation included in the results that are created by the computer to help you know how to interpret it. And there are links to decision support right in the system. So this has been a pain point for me in pediatrics over the years, and that's why we created CHADIS, to help people do more evidence-based care. So yeah, you need to learn how to use and interpret the tools, but we're helping you right in the process.
Yeah, Kristin, do you have a comment there as far as, you know, I'm sure you get autism screening tools and they're abnormal and they get sent to you, or does the pediatrician handle most of this?
No. So I think that the research is pretty clear that pediatricians, well-meaning pediatricians, really think that after 30 years of practice in general pediatrics that maybe they don't need to do a screener, or they don't need a screener because they know, and that's very well borne out in the literature. Similarly, you know, some barriers suggest that, well, where am I going to send them anyway? The wait lists are 2 years long. I'm not going to screen because I don't have anything to do. So I think it starts with education. And I think that self-education is one thing, but, you know, doctors are very much, the way that we're trained is very hands-on, right? So it's often the see one, do one, teach one model. And we kind of need that even now. So as a seasoned practitioner, you know, I kind of like to have somebody show me exactly what I'm supposed to do in a very simple way. And I think, like Barbara was saying, you know, these kind of case-based opportunities are a really great way to do that. And so, for example, I teach how to do an MCHAT and an MCHAT follow-up. And it was because of so many people being like, I don't do that. Or, you know, I do it, but I don't really know what to do with it. So I started thinking about it, and I was like, you know, frankly, yeah, because I would just kind of look at it too. And then not necessarily, I would usually, because I didn't necessarily need the MCHAT, I would just look at the kid. And so then I started thinking like, okay, well, if that's what I'm doing, then maybe I should actually learn how to properly do this so I can teach other people. And it's not hard, but I think for doctors who are super busy, they have to get past the, well, I'm not really sure, so I'm just not going to do it. Or I'm not really sure, so I'm going to make a shortcut. And so I think that, you know, strategies like CHADIS, strategies like Echo Autism strategies, any strategy that you like is important to do, but just figuring out the strategy is a really important thing because these kids are hard to pick up. So we know that about 1 in 6 kids has a developmental delay, and we know that we do not catch a lot of them, like Barbara mentioned.
Great.
And let me just mention that scoring is not always intuitive. For example, how to score the Vanderbilt, you know what? There's actually a standard for how to score the Vanderbilt, and it's not so easy. So having it done automatically by the computer is very helpful. But the other thing to keep in mind is you can't bill for it if you didn't score it. And of course, you can't always tell if it was positive if you didn't score it either. So it's really important to learn how to use these tools. And I appreciate your question, Nick.
Yeah. So I'll take a stab at this first one. And hi, Ron, it's nice to see you. So Ron, that's a great question. And I think this is tricky. So autism is not a straightforward diagnosis to make. Apologize, the cats. And so when you think about this, autism.
Kristin,
really...
sorry to interrupt. I don't know if everybody can see it because you sent it to the panelists. So
sorry. The question is, how important are questionnaires for a child's autism diagnostic assessment? Thank you, Mick. Which questionnaires are most effective to aid a doctor's diagnosis of a child? Great. Thank you, Mick. I didn't catch that. So again, questionnaires for the autism diagnostic assessment. This is tricky because autism diagnosis really does require essentially 3 things. Clinical expertise, so you really have to know what you're looking for. And so I always like to define that as a good understanding of the differential diagnosis of autism, a direct behavioral observation. That's an incredibly important piece to the autism evaluation, and then a comprehensive interview based on the DSM-5. So yes, you can be thinking about diagnostic assessment from a questionnaire perspective. However, you can't short circuit those other pieces. And so questionnaires are helpful. Gathering information from other areas, whether it be teachers, parents, whatnot, are very helpful. But things like the CARS, for example, things like it's going to also depend on your level of understanding of autism. So you have to know how to integrate your information gathering. It's really about the synthesis. So a lot of what we do on Echo is teaching how to synthesize that data, because I can't just have a parent tell me, all of the history and then not know how to interpret the history with what I'm seeing and with what I'm hearing from the teacher or the therapist or whatever. So it is more than just a diagnostic assessment questionnaire. Barbara, you want to weigh in on that too?
Well, I agree with you completely that it is, you need multiple sources of data. And actually, it's been really interesting. I've been doing autism research too, primarily related to improving screening at the youngest ages. And even the experts can't always be sure, because autism is an evolving condition in most children, particularly at the youngest ages. So having some tools to use can be helpful too, to be a little more objective, because boy, when you start telling a parent their child may have autism, they get very upset, which is appropriate because it's a tough thing to live with. So using something like the MCHAT for younger kids, the social responsiveness scale, social communication scale, the CARS, or the checklist for autism spectrum disorders. Those are all tools that can be very helpful, and a primary care provider can use them, and then together you look at the results. And you can often clarify the observation the parent has been making that's reflected in their answer on a self-administered tool.
And Dr. Howard, a few questions specifically on CHADIS. Is there a way to use it if you don't have an EMR? How can it be accessed?
Absolutely.
And is it proprietary?
Yes, it's proprietary. There's a modest charge per clinician per year for unlimited use of all the tools. Some of the tools, like the child behavior checklist, of course, we can't make those free because we have to pay the publishing house. But the pediatricians typically make between $15,000 and $35,000 a year of extra income by being able to do the extra screens that they might not otherwise do, and without the trouble with handling the paper. So we would be delighted to show you around. Just you can email me at chadis.com, or you can go to the chadis.com website, and there's a place for more information where you can sign up to get a demo from one of our salespeople. It is widely used around the world. Actually, it's in 46 states and 10 countries. So just like your Echo, there are people who are working on it. So please do get in touch with me, or go to the website and put your name in there to get a demonstration.
Wonderful. Dr. Sohl? Yeah, Dr. Sohl, would you like to talk through integration with Echo and NEMR?
Yeah, sure. So Echo, let me just make a clarifying statement about Echo. So Echo is really about professional development, and it's a learning collaborative. So it's not about integrating in the EMR. So it's more for you to learn and bring your, it doesn't even really have to be a challenging case. It's to bring the issues that you're thinking through in your clinical practice. So whether it be about developmental screening, whether it be you've got a kiddo with autism and they have constipation and you don't know what to do, or you do know what to do and you want to know if we think it's, if there's anything else you could do. Or, we have all kinds of different types of case presentations that you can present. Again, our teams around the country and around the world are typically made up of developmental peds, child and adolescent psychiatry, clinical psychology, a parent. Every one of our teams has a parent or a self-advocate, so a person with autism on the actual expert team, as we call it, and then a dietitian and a social worker. So essentially, the whole idea there is to give you a very interdisciplinary kind of look into your case. But what happens is you all come together. So it's about, like, for example, if you were to join mine in Missouri, we have about 35 to 40 primary care folks that join us twice a month, and they listen to cases from each other, and then they help each other with their cases. We help with the cases. And so that notion of all teach, all learn, that's this learning collaborative. So it's free, it's no cost, it's CME. And then also we typically will also run MOC Part 4, again, because I said I'm a QI junkie. So I will, depending on my interest at the moment, will make MOC Part 4 modules to go with the whatever we're doing. And then you can earn your MOC 4. We are dabbling in MOC 2. Oddly enough, that's actually a little harder than MOC 4. Why? I'm yet to figure out. And so harder to get the credit certification. So anyway, it is a little different. And so we are teaching you how to fish is another way to think about it. And so it's professional development in that way. So it's actually very much a complement to what Barbara does. Hers is very much what I see as like a great amplifier to your practice, where you can get families engaged in doing the screeners, the evidence-based approaches, and all of those things. What we do is teach you how to approach the family, how to think about the family, how to build your clinical expertise. You're going to get that from Barbara's work too. Please don't misunderstand. I'm just saying, like, this, what we're doing is like a learning collaborative approach. And so it's just a little bit different.
Let me just mention that CHADIS offers MOC Part 4. We've got 6 different programs to choose from, and there's no chart review required because the data is being collected by CHADIS. So that's an advantage. Those MOC sessions are webinars to talk about clinical aspects of care for the different topics of MOC. So substance use, ADHD, social determinants of health, autism and developmental screening. Those are all the ones we have right now. So I strongly believe in the importance of MOC and the process, because this is it's a growth process for us as clinicians as well to participate in quality improvement projects.
Yeah, so you both see, just to kind of sum up a little bit. So, I think you've really driven home that screening works, right? And it's something that we need to do more of, not less of, right? It's not something that should just be put on the shelf, that it combined with good education and understanding really is a key driver, right? So the screening is without a question. How important is it to stay connected? The longitudinal, we hear a lot about drive-through medicine and, hey, just go see anybody and things like that. I would assume in what both of you do in developmental and behavioral pediatrics, the continuity of care, maybe that's the advantage of virtual care, telemedicine, that you add that. Are you seeing patients more frequently with telemedicine, or is there ability to stay connected, or is there like a remote ability to follow up with these questionnaires more regularly? What do you see kind of going forward, and how all this virtual care changes things?
Well, I think that that CVS and Walmart are huge threats to general pediatrics, and because it's easy, and if we don't sell the concept that continuity of our relationship with the family and the kid is really important, then we could really lose the ability to have private pediatric practices available. So I am very concerned about it. And I think that having telemedicine as a component to your care to make it easier for people, that's why they're going to CVS, because it's easier. Now, you know, they also can do it at 11 o'clock at night, which is maybe something you don't want to do. But I think that it's been difficult to measure the value of continuity. I personally have no doubt that it's important, but it's not important for the things that the bean counters are counting. So in other words, it's probably not important for growth in height, let's say, that's something you're measuring. People maybe grow just as well if they get their care at CVS. But the real thing is that getting to know people and having them trust you is critical to adherence to programs, picking up on comorbid conditions, and early detection that allows for easier treatment and more successful treatment of all kinds of conditions. So you can see I feel pretty intensely about this, not just because I'm a pediatrician, but because I think that the thing that is of value in continuity is often not being measured, and so not appreciated by the public.
I'm going to chime in. I will do my best not to repeat because I wholeheartedly agree with you, Barbara. So as again, leader in the American Academy of Pediatrics, I definitely think that we need to be very much thinking about how we can maintain the important role that we have as the medical home and in continuity of care. Let me give you a nutshell version of an example from a developmental behavioral pediatrics perspective. The importance of what we do is that we know the difference between when a kiddo calls. So I'll just give you a really concrete example. So I have a patient who has autism, and he's a very literal little guy. And so he routinely makes threats against his little brother and his neighbor about killing people. But okay, I've known this family for a very long time. And so you might be thinking like, oh gosh, right? Okay, but that's not he isn't. That's not what's happening. Now, if I didn't know him and I got a cold call, or I was a doctor at CVS and mom called with he just drew a picture of an axe and said he was going to kill the neighbor, what do you think would happen, right? He would get sent to the emergency room, probably admitted, who knows what, even if mom tried to describe that he has autism and he has this and he has that and all these things, right? So cost to the system, cost to the family, major medications, very highly likely, all of these things. And I could tell you stories until for all day long about other children with similar situations, maybe not so violent, but I have to say that I've known this family, I've known this child, I've assessed this child all over the place. And I can assure you that that is not the course of action that needs to happen. And so by having continuity, by knowing the family, by shared decision-making, by that relationship, we don't have to do any of that. And so sure, is that something that comes with experience? Yeah, but you have those same stories in your patients with, vaccines, right? Or what have you. So the same stories that you have with your vaccine hesitant families or any of those situations, that's the value in continuity of care. And so certainly when we're in a situation with COVID or what have you, the value that's placed on a trusted relationship with your your pediatrician can't be underestimated. And so while I understand, and frankly, I was actually thinking about this because I need to make a doctor's appointment, and I was like, oh God, I do not want to go in. I wonder if she does telehealth. Honestly, this morning I was thinking about that. And yeah, I mean, to be really honest, I weigh those thoughts in my mind all the time. Like, I wonder if I could find anybody, because I don't want to go anywhere. And so we do need to think about that, because our society, especially now with the pandemic, it was already there pre-pandemic, but it's definitely here now, doesn't want to have to leave their office, change their schedules, do all of that stuff. So we have to adapt. And there are so many things that we can do through telehealth. There's plenty of things we can't, but there are plenty of things we can. And so certainly I think I'm preaching to the choir here, but we've got to figure out a good solution to offering that convenience / quality, or the balance between the two, And it can be done. It can definitely be done. And I will tell you, families, absolutely. So I had a mom tell me on Tuesday, because I said, okay, now next visit, we're probably going to do in person because it's going to have been about a year. And she was like, I don't know. I kind of like seeing you in my pajamas. And I said, well, you know, I kind of like seeing you in my jeans and no shoes. So I'm right there with you, but we're probably going to have to get some vital signs. And so again, right, we've got a lot of work to do. A lot of policies need to be made about what is the frequency of vital signs? How do we do this safely? Blah, 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 right? There's a lot of things that have to be still hashed out. But I can tell you, families definitely appreciate the access to their provider. And it's our voices that have to be out there saying continuity matters. Let us do it safely. Let us do it wisely, and really making those voices heard.
Yeah, no, I want to thank you both for your time. Oh, Barbara, go ahead. One last comment.
Oh, I just wanted to mention, because I don't think Kristin mentioned, that there are now remote diagnostic services for autism available anywhere in the United States through an organization called Behavior Imaging that uses a NODA, remote autism diagnostic evaluations, where parents collect videos of certain scenarios. They're told which scenarios to get that can be accurately helpful in doing autism diagnostic evaluation. So I just wanted to mention that as well as a resource.
Yeah, no, thank you both very much. I mean, I think ADHD, behavioral health, mental health are just so important for, you know, for an opportunity for telemedicine to really make a huge impact, right? We can argue, to your point, hey, we can't take vital signs. How do we do this? How do we do that? But our ability to stay connected, have continuity, do screenings, do follow-up, ensure patients are getting the care they need, I think is right in that perfect wheelhouse. And so I appreciate your time and putting everything together on the content and sharing your expertise. Dr. Sohl, Dr. Howard, really appreciate it. I think hopefully you gave folks really good insight. I know that I'm one that, you know, as an ER doc, I'd be the first to admit that, kid, right? You know, we talk with other docs that do palliative care, hospital, you know, chronic care. There's so many things that just I can't do. I don't have the continuity and the relationship. So I'm a big proponent for continuity of care in the medical home and everything that you both are doing to influence that. So congratulations on your work. Thank you for your work. Keep it up, and I hope everyone stays safe. And thanks again for your time. And sorry we went over it a little bit, but I think it was worth it. Thank you all very much.
Thank you.
Okay, take care.
Bye-bye. Bye-bye.